Whether because the patient's legs are heavy, or they're uncomfortable in side lying, or you're not able to get the sacroiliac joint to do what it needs to do, you can elect to do the same counter-nutation technique in prone. We ask the patient to be positioned prone with the break of the table halfway between T8 and the segment we're treating. In that position, we're now going to ask her we're going to extend the table and then ask her to put her left arm under her so she's rotated to the right. In this position, she's side bent to her right, rotated to her right, and now I can shift her pelvis further where her uninvolved leg can now be gently lowered off of the table. I'll ask her also, I can put a pillow underneath her shoulders to maintain the rotation this way. Now, in this position, I'll cradle her involved side lower extremity in this position with her lower leg outside my brachium. I'm going to now extend her to the end range of hip extension, and in that position, I'll reach down with my left foot and scoot her left leg, let your left foot down, left leg forward into more flexion. I can use this leg at the hip by abducting to maintain the right side bending. At the same time, my mobilization hand is in contact with the PSIS and posterior iliac crest. I can also, in some patients, use the rotation of the hip to control a level pelvis and level sacrum. I'll scoot her right leg forward only to the point where I start to feel her pelvis shift. And now what I'm going to do, I'm going to move this arm up so they can see it. I'm now going to lift her into further extension to the end range, and with my elbow flexed on this side, I'm going to create a thrust, high velocity force of low amplitude in a ventral, lateral, and cranial direction on the PSIS and posterior iliac crest. So I take up the slack, I get her to take in a breath, let it out again, and then I take up all the slack, and then hop, a high velocity, low amplitude technique. I can then lower her down, let this leg down, I'll reach down, help her back up with this leg, here, lower her extension down, take out the pillow, and then go back and retest the tests that were positive. We expect with these types of techniques that symptoms will be reduced during her provocation tests, and then we can move on to checking again for instability. Because in the event that a patient had a locked sacroiliac joint, we unlock it with one of these manipulations, then we would suspect that they might then appear to have an instability in the joint system.